I appreciate the opportunity to really speak to the group today, and thank you to the Academies for hosting this on such an important topic as population health. I really want to do a few things today. I want to focus on what our journey of our hospital, which is a small community hospital, Margaret Mary Health in Batesville, Indiana, what we've done with regard to population health, and really give you a perspective of what it's like in the world of population health from someone that hears crickets at night. So what's it like on the front lines? What are we doing? What are we succeeding at? More importantly, what are we failing at and what have we learned? The final thing is really honestly to convince you that rural health has been and will continue to be the leader in population health. Our physicians are primary care by nature, and so much of what we've learned has really come from the fact that this is about primary care and prevention. You've heard a lot about social determinants of health and how that works, and really that is the focus. So when you think about what's happening in rural areas where we're a small community microcosm of healthcare delivery, we can be very effective in this world. So that's part of my goal of convincing you. This is a picture of Margaret Mary Health. We were formed in 1932. That is the original building. So 3 years into the Great Depression, this community came together and said, what can we do about helping each other, helping the neediest of our communities? Our mission statement is up there to improve the health of our communities. And quite honestly, that's the mission statement, or very close to it, of every hospital, every rural hospital in the country. That's really what we do. And it aligns so well with population health. How do we make our population healthier? So it's not about being a global presence or anything like that. It's our world and making that so much better for the people that we see and know and care about. And I'm trying to advance my screen here. And it's going to be working. There we go. Okay. Just to give you an idea of what we do. So we're a critical access hospital. It's a rural designation. Many of the hospitals in the country that are critical access are 25 beds. So they have to be 25 beds or less. So there's 1,300 critical access hospitals in the country, and all of them are 25 beds. But bed size really does not give you an idea of what's happening at that hospital. So when you look at us, we deliver roughly 500 babies. We see 20,000 ER visits. We employ just short of 800 people. So that's kind of the size. We're halfway between Indianapolis and Cincinnati, about an hour from each. And really that's who we are and what we do, and sets us up really well for population health. When you look at what we did, and I'm still struggling advancing my slides to the next one, and you look at the fit of the mission of our organization, it fits very well. And our transition to population health really started about 6-7 years ago, and we wanted to be part of it, but the most viable solution was to be part of an ACO. And you had to have 5,000 lives, and rural hospitals don't have that 5,000 Medicare lives to be part of. So we were talking about this really at a board retreat, and when we realized we needed to be part of this was a presentation that a gentleman gave to our board. He said, look, population health is about my grandma. He said, I love to play with my grandma. It was a wonderful situation, and I'd go and we'd bake cookies and do all these things together. But one time I visit my grandma, and she's in a wheelchair. I didn't understand. She had diabetes, and I knew that. But one day her diabetes got worse, and the hospital had to cut off her toe. And I couldn't play with my grandma as much as I wanted. The next time I visit, my grandma's in bed because her diabetes had gotten worse, and the hospital had to cut off her leg. And it didn't make sense to me. But when that happened, I realized that the hospital and the doctors were paid to do things like that, but they're never paid or incentivized to keep my grandma's diabetes under control. And he looked at my board and said, we're better than that. We are better than that as healthcare people in the country. And better for your community? And my board of 201 looked to me and said, we need to do this. We need to be part of it. And it started this journey that we went down to be able to offer population health to our communities. And some of the things we've learned really as we go forward is that we had to partner with a lot of other people. Very first of all, we had to form the first national rural accountable care organization with 9 other hospitals, California, Michigan, Oklahoma, and Texas, to be able to work together and learn how to do this, get the 5,000 lives, and then be able to improve on what we were doing. So that ended up taking place, and it created this collaborative effect. Next slide, please. What we learned, we went in with very good intentions, but for the most part, everything we did to begin with was wrong. We made it part of the hospital. We focused on the 90-10 rule, where 10% of the population takes up 90% of the cost of healthcare, or the 80-20 rule, or something of that nature. And we thought about it from a hospital perspective, and we were trying to keep people from the edge of the cliff. We were trying to keep that CHF patient, COPD patient from going over the edge of the cliff, and it didn't really work well. We end up realizing that it's not about the high-end patients. It's not about those patients that are right on the edge. It's about keeping people healthy. So we need to move closer, and we need to move closer to the patient. We went to the primary care physician's office. So what do we do to focus on prevention? What do we do from that perspective? And as we learned this, as we went along, it's more about getting close to the patient, getting close to the patient's home. What are they doing in the home? So that ends up being really where we ended up focused, and realizing that in the first couple of years that it wasn't a hospital focus. And I think that's why rural can really lead in this. So the next slide, please. We ended up partnering with these hospitals, and we shared our successes and failures. What's really going on? What are you doing to have success? And this is different than urban hospitals. When you look at it from a rural perspective, we want the other rural hospitals to be effective, to be competitive, to really have good outcomes. They are not looked at as competition in any way, shape, or form. We really want them to be successful. So we shared this back and forth. The other thing is this treasure trove of data that came out, and it's really necessary to do population health well. Medicare shares on these 2,000 patients that we've been attributed this absolute treasure trove. Now, many of you realize that without data, you end up having this concept where you're just guessing at things, and then you end up getting data. Hopefully the data leads to information, the information leads to knowledge, and eventually we'd like to get to wisdom. Before we had the data, we were just guessing at things. And this really came out in a meeting I had with a physician, because we were looking at all of her information on the patients that she had. She had the highest cost for pharmaceuticals. So we're scratching her head and saying, well, I prescribe what everybody else does, and I don't understand what's going on, but I'm really an outlier because her pharmaceutical costs were 20% higher than everyone else. When we ended up going through that, we found out that her ER costs were much lower. And that ended up giving us so much information about she was able to do things to get people to fill their prescriptions. So it's about, and you can go to the next slide. It's really about what we learned and how we got closer to the patient, putting care coordinators in place and things of that nature, nurses that work with the physicians. And this really became a big issue when the pandemic hit. Now, some of you may have heard about this. The pandemic's been in the newspapers, but we were really hit early on. So it was Friday the 13th of March when we started our first patients. And this is one of our physicians, Dr. Michelle Shorten. She made a picture in the New York Times wearing a mask. So she was excited, but her family wasn't. But she was instrumental, like many of our physicians, in being able to adapt our organization. She's primarily an outpatient physician, but when the pandemic hit, we went from an 80% outpatient facility and 20% inpatient to a 20% outpatient facility and really 200% inpatient because of all the patients that were crashing in our area, one of the biggest hit rural areas to begin with. We had multiple issues going on with that, and our focus and my focus really moved to being able to go to what's happening with the virus, but in addition, we had these 2,000 patients that we were responsible for in the ACO. And it helped knowing that, one, they trusted the care coordinators they were working with in the physician's office, and two, that their diabetes, their high blood pressure, their COP and CHF were under control. So there was really this big learning experience of being able to have patients which were most vulnerable to COVID, being able to have those chronic diseases under control. So even during a pandemic, having that population health focus and having a healthy population really helped us quite a bit. So next slide. There's a big study, and you're aware of the meta-analysis that was done that proved that an ounce of prevention is worth a pound of cure. Today, we live in a world where, honestly, we're paid for cures. When you look at what the reimbursement models for healthcare are, they're being paid to be the best toe and leg amputation center you can be, not the best place to prevent diabetes. That's not where you get paid. So how do we move this? How do we change that focus on prevention? We know it makes a difference. It's easier for us because I know the people that we're having this effect on. And I honestly just want to be able to share with what we're doing in the future is really the annual wellness visits. This was a real struggle for us. We try to get patients into the hospital, in to see their physician before they're sick. And the feedback from our patients is, why do I need to go to the doctor? I'm not sick. So that concept of getting you to be well, getting you to stay healthy, focusing on screenings, prevention, immunizations is a big, big deal. And that's where our care coordinators, our nurses that work with the physicians really are successful. So really in closing, I just want to convince you that because rural is a microcosm of the world, very small, we're connected, hospital CEOs and other leaders in EMS or health department meet on a regular basis. We all know each other. Rural communities are mission driven about keeping our communities healthier. The chief of staff in a rural hospital is a primary care physician, not a cardiovascular surgeon or a high-end researcher. So it's focused on this to begin with. And a board meeting is not going to be, the agenda is not going to be driven by the latest cancer proton beam therapy or how our transplant program works. It's going to be, how do we do the basic things to keep our patients healthy? And I think that's really the key of population health and getting population health to be successful. So that is what we do at Margaret Mary, what we're focused on, and what we've seen is this has been duplicated at small communities across the country and really has a chance to be able to be successful going forward. So thank you very much. And I am, at this point in time, going to turn it over to Keith.